All right, so we've heard the surgical side of things. We've heard something about gastrointestinal point of view. Our next speaker is going to speak about interventional radiology, which offers quite a few excellent options for therapies. So, as you guys make your way back to your seats, I would like to bring up Dr. Sandeep Vaidya, who's going to speak about interventional radiology.
Thank you, Bob. Am I loud enough for people out there? So I'm going to be talking about interventional radiology, and I did not feel bad about Eric saying anything about the diagnosticians because I don't sit in the reading room. And I would love to say that I am in direct competition with you for getting things done. My motto is see tumor, kill tumor. Good enough for me. Okay. Except when I have to try and use this. Okay. Technologically challenged for this thing, right? No. So essentially what I do is something called as interventional radiology. Everybody thinks about a radiologist as somebody who reads a CAT scan, an MRI, or an ultrasound. That's where we came from, but we are the kinds of people who did that and felt that was not enough for us, and so we wanted to do something more. We missed patient contact, so we started doing procedures, and then we started doing them well. And we started doing them better and faster and with smaller incisions. And then we pissed off the surgeons. And that's why. So that's why not many surgeons liked us for a while. But then once we started bailing them out, they came around and started helping us. Eric? Okay, no. No. So essentially what we have options for are mainly what I'm going to do is give you all these concepts in terms of if something turns up in the liver. A lot of these concepts can be utilized for tumor or metastatic tumors that turn up outside the liver in a limited fashion. But the idea is just to give you a concept of this so that you kind of have some information. I'm not going to go into details because that would mean that we have a extensive clinic visit on a Saturday while you are having lunch, and that's not what we want. So two things, broad divisions. One is catheter-based therapy. Everybody knows that an angiogram for the heart is, but little do they know that angiograms mean study of blood vessels, and you have blood vessels in places other than your heart, otherwise you wouldn't be here. So essentially catheter-based treatments is what you can treat by using a catheter in an artery. There's radioembolization, or where we're going to essentially nuke your tumor in your liver to try and kill it, because as we know, apart from cockroaches, nothing else is going to survive a big nuclear bomb, right? Then is a transarterial embolization, which is not very often done, mainly done for people who have a lot of carcinoid syndromes, very bulky disease like the dandelions throughout the liver. But that's just using to cut down the blood supply so that you don't have too much of enzyme releases, chromographine release, etc. Chemoembolization, as was mentioned before, really doesn't work for these. The heart of the matter is percutaneous ablation, and the fancy toys that you were shown in beautiful videos that I don't have videos for, but still pictures, are something that we do as. Okay. See, I was going to ask you, where do you get all those things from? Okay, so let's start off with the ablation part of it, because that's more easy to understand. The ablations can be of different types. One is radiofrequency ablation, where we are heating it up and burning the tumor. Cryoablation, where you go to the other end of the spectrum because we can't make up our mind, we want to burn it or we want to freeze it. Then that's not enough, so we said, let's microwave it. And then we said, oh, that's not good enough for us. We need to electrocute you and have the nanoknife. So radiofrequency ablation start off with burning things. So Hippocratic oath. Everybody knows that the doctors have to take an Hippocratic oath. We're not hypocrites, but this is what he said, and we live by that. No? If something can be killed with fire, almost anything can. We will do it. So what we're going to do, how it works, how do we do it, what do we do, and what bad things can happen. And that's the part I'm going to downplay so that you don't get scared. So radio frequency, think of the alternating current at home. What does it go through? It goes through 60 cycles a second. When we treat you, we are going through more than 100,000 cycles a second, and the reason is because that will cause increase in tissue temperature, but it won't cause rapid firing of nerves and muscles. So that's how we can kill tumor, okay? This is just a simple way of showing that we do this in a fancy way to electrocute you, all right? We're going to stick a needle into you. That is one electrode. The other grounding pad is going to go to the generator and complete a circuit with you as the guinea pig in between. No. So essentially, you're not a guinea pig. The guinea pigs, a lot of them laid down their lives so that we could do this for you. So these are the return electrodes which are put on their thighs. There are certain parameters. You have to put them so far away from each other, so far away from the site, etc. Again, if I start doing that, I'm going to be doing a clinic visit which you'll get thoroughly bored and start falling asleep. So, it uses a high frequency alternating current. So, I would say 100,000 cycles a second is pretty high. I can't count that fast. It heats the tissues up because what it does, it agitates the tissue molecules, it causes friction, friction causes heat, and once the heat starts building up, there's a level at which it will burn off tissues. So, the technical term, if you want to impress your physician, is thermocoagulation necrosis. All right, say that you want ablation to cause that. This is exactly what I said. It causes vibration, tissue heating, and burns. One of the things we want to look at is, now this is a little bit technical. I've tried to cut out as much technical stuff so that it doesn't annoy you. If we don't heat the tissue to certain levels, we are not going to get good results. And if we heat the tissue to too high a level, it's going to burn things too fast and it's not going to give us good results. Kind of like if I try to cook something, I either don't, it's raw or it's burnt. But there's that fine balance. You know, the top chefs have this thing where it's just right, medium rare. Medium rare doesn't cut it, okay? So you have to have something between 60 and 100 degrees to kill the tumor. And about 70 degrees is when you start worrying about you're getting too warm or too hot. If you take a pinpoint source of heat at 70 degrees, and these are all Celsius, not Fahrenheit, it is going to cause tissue damage up to a centimeter, and about 80 degrees Celsius is about a 1.5 centimeter damage. Okay. If you go too high and too fast, what it does, it chars everything. You just get carbon buildup around the probe or the needle, and then that doesn't transmit any heat any further, and the whole thing's just shut off. So this is a very fancy way of saying the same thing. Okay. This is a tumor that we treat. So what you see right in the middle is the part that has been cooked and killed, and then you see this brown ring around it, which is the inflammation that happens around the tumor that has been burnt, and that's tumor hypervascularity, as we call it, or hyperemic rim, not tumor hypervascularity, that shouldn't be there, sorry. And then the rest of the liver appears untouched. So that's what we aim to do. As I said, the challenges which I kind of talked about while we are going is overheating and heating it too fast because we'll cause charring. Underheating, so we won't kill it, we'll just tickle it. And then question is whether the size of the tumor is good for treatment or not. We have to make sure of all those things because sometimes tumors are too big to do this, sometimes they're too small to be able to be targeted as well. So one of the things we also have to look out for is something called as a heat sink effect. And think of a car radiator. A car radiator is going to keep your engine cool. A blood vessel with blood flowing through it, and a reasonable sized blood vessel has reasonable sized blood flow, it's going to work in the same fashion. Okay? So what's going to happen is you poke the tumor, you have a big blood vessel sitting right next to it, you're going to kill most of the tumor, but that fine rim of tissue around the blood vessel is not going to get heated up and is going to survive. And that's when you have your recurrences or residual tumors. You can see this. Does this thing point? Oh yeah. Not a very good angle, but if you see this, these are the two big blood vessels, and this is the tumor, and the burn has tried to go in between them, but it kind of stops short. And so this is where you'd find tumor recurrence or tumor not being treated. All this is fine. So those are the kinds of things we have to look out for or think about. And if the tumor is too big, just putting in one needle is not going to do the job. Or if you have only one needle, in which case you should ask your technologist, why don't I have more needles? You would have to have more burns done. So you're going to do it in a piecemeal fashion. So you're going to do overlapping burns. So you burn one area, reposition it or move it, burn another area, kind of get, all these pie charts that have intersecting circles, etc. You go along that, that concept. Which comes down to then what am I going to select? I have many toys to select. I don't know, Eric showed one, we have about, at least 4 different types. And the reason to have these is each of them burns in a slightly different fashion. And the burn that it creates, in an ideal scenario, if you go to a tissue that is non-living and you burn it, it'll give you a nice sphere. Real life is different. Real life is not ideal. If it was ideal, none of us would be here. I would be out of a job. So there are different probes that will work in different fashions and will burn in different fashions. Some will burn faster and give a different size burn. Some will give a different shape of burn. So this one will actually give a burn which is oval along the line of the probe. So it will be more along this axis, as we call it. There's another, and this is the generator that we hook you up to. It's showing a lot of number of readings. Most of them are going to be temperatures, which will allow us to see what temperatures we are achieving. This is a different kind of probe. Think of it as an umbrella without the fabric. This is going to give us an oval burn, which is perpendicular to the probe. So that is because ideally you want to burn everything, and in a perfect world, again, all the metastases are like nice round balls. But they're not. They're like M&Ms, flattened to one side or projecting on one side, and they can be oriented in a different fashion. One might be along the path that your needle is going. One might be across, and depending on that, you can choose one versus the other. Then comes something that is a lesion that is, it's close enough to the diaphragm, let's say. It's something that we don't want to burn too far beyond the tip of the probe, because if you look at this slide, the burn is the oval, gray oval that is surrounding this umbrella-like thing, and you see that it burns beyond the umbrella-like thing. When you don't want that, when you want it to stop precisely, then you have something called as the cool tip, which what it does, this one does, is it burns only a millimeter or 2 beyond the tip of the probe. Now again, you can either use 1 or you can use 3 depending upon the size of the burn that you want. Sorry. So that's the reason why we have so many toys, and that we can spear you with so many things to try and burn you to give you the right thing. Okay? I mean, if it's not as if, he looks like one that will use an umbrella and he looks like one that should have the other one. No. Okay, and when we start burning, regardless of what happens, or regardless of which probe, except the last one, what happens is the individual needle points in all of those probes start burning and creating this kill zone around it. And once the kill zone first starts, this is basically if you have 4 points of burn, and then it becomes bigger and bigger and bigger and ultimately produces this big cavity or this big kill zone. And this is how spacious and luxurious we are. We're all tripping over each other for trying not to trip onto you. Okay? Thank God you're under anesthesia and you don't know that. So, having said that, when do we decide to do this? We decide to do this whenever we know that Eric's going to take him for surgery and we want to hijack the patient. Okay? So, not really. So what most of our discussions and decision making is done in a multidisciplinary board where there is a surgeon, there's a transplant surgeon, oncology surgeon, radiation oncologist, interventional radiologist, medical oncologist, everybody and their uncle and aunt are there, except the patient. Because the patient has been seen in clinic and now we want to have these discussions, and these discussions can get pretty animated. And we don't want you to see that, because it's not that we are fighting over things, it's just that there are a lot of positives and negatives for each, but then we want to come to a conclusion that is suitable for the patient, that's the best for the patient. So, and honestly, it's not that we want to keep you out of the loop, it's just that when we are discussing things, a lot of times patients can pick up on one statement and then get stuck on that, even though that may not be it. So that's the reason why we have these multidisciplinary conferences. After we see the patients, and the patients unfortunately have to wait for a little bit, but that's the advantage is in one day you get the decision and you meet with the right person. So when we are looking at it, why I see a patient that has is good functional status, 1 or 2 lesions, small enough, not too close to important or critical structures, then I want to do an ablation on that person. And of course, if I can see it well with either ultrasound or CT, then I want to do an ablation, because the ablation has been shown in surgical literature, not IR literature, because surgeons always laugh at us. In surgical literature themselves, they have shown that ablation, when done well, is as good as surgical resection. And of course, we don't have to fillet you open, and we don't have to take off so much of liver tissue. Granted, liver parenchymal sparing surgery is done, but that still will take out a lot compared to an ablation. So if at all it does turn up that we are going to do the procedure, we are going to meet with you, we're going to talk with you, tell you what happens, tell you whether we are going to burn you, electrocute you, freeze you, whatever it is. We are going to have you meet with the anesthesia folks, because these are done with anesthesia. There are a few places that do these with sedation. We don't. It's just our preference. We will make sure that you have an ultrasound done so that you can see it with ultrasound, because that is the preferred, fastest and real-time placement of the probes. If that's not possible, then we'll have to set it up with CT. It's a little more cumbersome, but not the end of the world. And then we're going to make sure that when we poke you, you're not going to bleed like a stuck pig. Okay? Most of you have good normal liver functions, because you have secondary metastases and not underlying liver disease. So that's not that much of an issue most of the times. But with long-term treatment or long-term chemo, etc., things can go awry. So the example, this is a planning ultrasound where you can see that, here I go again. That's the tumor. There is a vein right next door, but there is decent amount of space between the vein and this that we could manage to get this done without having the heat sink effect. If there is going to be a heat sink effect, there are other things that we would do to temporarily slow down the flow, block the flow, whatever it is, so that we don't have that issue. Or we might do something else completely other than ablation, which we'll come to. So who's the ideal patient that I would want to walk into my clinic every time? It's somebody who has not had treatment before, his liver functions are immaculate, who has just 1 lesion, it's small enough, it's easy enough to get, it can be seen easily with ultrasound, has no anesthesia issues, okay, and has perfect blood parameters. How many of those criteria are filled every time? None. If I have one patient walk in with all these parameters checked off, I'm going to stop practicing the next day. Okay? Most of the times, we get people with challenges, because more lesions, large lesions, they're close to the gallbladder, close to the diaphragm, close to stomach, colon, things of that nature, or we can't see them. Although nowadays, just recently FDA has approved ultrasound contrast, which has changed that dramatically for us. So we can see more lesions now than we used to be able to. So all those are challenges, and not really people that we would turn away, that we'd have to work a little more. Once in a while, after the ultrasound, we might say, you can get an ablation done, but I can't do it because I just can't get to it safely enough, in which case, Eric, you'll be up. All right? And then he can use his robot and look into things and do whatever. Then there are people who we flat out refuse, because there's extensive disease. Now, people with the dandelions in the liver, obviously you can't do this for them. There's a limit to how much you can burn the liver, even if you want to do it all the time. Okay? If your liver function because of adverse reactions to chemotherapy is abysmal, then the moment we touch your liver, we're going to kill you. We don't want to do that. Or it's invading into major blood vessels or compromising major blood vessels. We try to do that, it's going to send showers of tumor cells into the blood vessels, and you're going to land up with new mets everywhere. So those are the kinds of people that we would want to respectfully walk away from. Okay? Once we have done what we have to do, and we do that well, We are going to follow you up. What we like to do is get a scan done again in about 1 or 2 months. More likely 2 months than 1 month, because the sooner you do the scan, what does it look like? Any idea? It looks like a bomb went off in there. Literally. Looks like a bomb went off in there, and then that causes panic, and that panic translates to the patient, and the patient's panic translates into phone calls. The phone calls translate into panic fellows, and panic fellows call the attending, and always this happens at 2 in the morning. Okay? And then you have to make sure that the patient, the fellows, you have to calm the patient fellow down, make him climb down the wall so that the fellow can make the patient climb down the wall. And then the next day you call the place that did the scan and said, why the hell did you do it so fast? Okay. Now, what happens is when we do the burn, everybody asks, what happens to those tumors? So it essentially gets replaced by scar tissue, and sometimes you just get these big black holes in them. And these holes kind of, over time, just shrink away. And this is just a slide showing you the evolution of those RFA cavities. This is how it was 1 week, a little too early, of course, but then it goes slower, smaller and smaller, and by 6 months it becomes really very small. And this is just a diagrammatic representation of how it changes. Okay. And when we do this, we can get a whole lot of things that can be a problem with the procedure. These are what we call as complications, not side effects, but complications. And there's a big long list which we make everybody aware of. The ones that we are very concerned about is something called as tumor tract seeding, where, remember, we're putting needles into the tumor, and when we burn them and we pull them back out, there is always that one possibility of that one stray cell sitting and hitching a ride on that needle, and then on the way out, setting up shop somewhere else. So that's called tumor tract seeding. And to avoid that, what we do is on our way out, we always burn the tissue tract as well. So essentially give you something that looks like a lollipop burn. Okay? So try and prevent that. Now, having said that, never say never. I always tell my patients, I will never give you 100% guarantee of success, and I will never give you 0% complication rate. If somebody does promise you that, say thank you and run away. Okay? One of the things that people say is that, what will I feel afterwards? You'll feel as if you've been sucker punched because we're burning something. We've poked you with a needle, burnt you. It does feel sore. You will feel like you have the flu for about a week or so. It's called post-ablation syndrome, and it's seen almost every time. Okay? And these are the patterns of tumor progression if we don't do a good job. We never want to see this. It can be in different fashions. We can have little small satellite lesions. One edge of the tumor might survive. And this is just diagrammatic representation. But whenever we see this, we say, oh God, now what can we do for this patient that is going to take care of this? Because these become much more challenging, because you're trying to go into an area that has already been treated, is very difficult to see with ultrasound. Again, with contrast, it's becoming much easier, so we are not as worried about these as nowadays. But it's never nice to see something like this, because that means you didn't do a good job in the first place. So a specimen of an undertreated tumor. So this part of the tumor is still active. The other one, this is something you can just see when you actually feel the specimen. In a picture, you can't really see it well because it all looks white. And then, of course, in pathology, it'll be different. And this is the dreaded complication of what I said, tract seeding or peritoneal seeding. If you see from top left, this is what it was. Originally, the lesion that was treated is not in the pictures, but this is just to show you what can go wrong. It doesn't happen that often. I've personally had only 2 patients in the last 13 years that this has happened to. So, knock on wood. Okay. So, having said that, the other thing that we can do is, where is Eric? Eric and his chopstick therapy. Okay, so this is where we electrocute you. It's called nano knife or irreversible electroporation. It's a little more challenging. It uses high voltage electrical pulses, not to heat up the tumor, but actually to degrade the cell membrane of the tumors. And that's how the DNA of the tumor cells is degraded, and that's how the cells die. Okay? The advantage is, like Eric said, we can do this even if there are blood vessels close by, because by some magical reason, which I don't understand, normal tissue for the blood vessels or bile ducts does not get affected. Um, how that doesn't happen, that would need a cellular biologist, and which I am not. So think of it, this tumor, this is right next to a big, this is the tumor, it's the portal vein, kind of important, right? And this is another tumor right next to the IVC, so another important thing. So this is something that we would not be able to ablate safely, but this is something that we can do an IRE or nanoknife for. The challenge with nanoknife is that you have to place multiple needles necessarily. The bigger the tumor, the more the needles, and they have to be placed very precise. So the technique for these is you have to put these probes about 15 to 20 millimeters apart. Their tips should not be more than 5 to 10 millimeters away from each other, so one should not be too deep and one should not be too far. They have to be parallel, and you can do that easily with 2 needles, but anytime you have a tumor that's more than 1.5 centimeters, you're looking at 3 needles, 2 centimeters, you're looking at 4 needles, 2.5 centimeters, you're looking at 5 or 6 needles. Now imagine how difficult it is to get all these needles perfectly parallel within 15 to 20 millimeters and within the tips being 5 to 10 millimeters of each other. It is unbelievably difficult, which is why most of the time for this procedure is in needle placement, especially if you are not opening up the patient. It is relatively easier to do this in a true surgical manner if that is being done as part of something else, because you don't have a lot of ribs or bony structures that you have to navigate around. But when we are doing this purely percutaneously, imagine trying to do this in the liver through 2 different rib spaces. It does become a challenge. So it's not impossible, it just takes a while. And we have to have you completely paralyzed, because once we start putting that electrical current through you, you're going to, if you're not completely paralyzed, you're going to look as if you're having a seizure. So that's a tumor right next to the blood vessel. This is seen on ultrasound. The circle is where the tumor is, the red is where the blood vessel is big enough. So that's what we do. Those 2 bright lines, those are 2 of the 3 needles that were in the tumor. You can see they're pretty good parallel, almost at the tip with each other. This is how it looks if you take a CT of them. We measure this distance, and this distance, and this is how it looks on the outside. So once we do that, what we are going to do is we're going to send those high pulses between these 2, then between these 2, then between these 2. Because then what happens is, going back to this picture, this is how the burn happens between each pair. So it's a pair that creates an oval area of depth, and then when you add those pairs between each of those needles, that's how you cover the entire tumor. And if you see that was the original tumor. This is how it looks like, those 3, and then this is how it progresses, and that's what happens. Okay. Most of these, whether it's IRE or ablation, we usually send them home the same day. With IRE, because you are completely paralyzed for a long time, because the secondary effects of those complete paralytics is that you can be severely constipated, and that becomes another problem, is because you can't give pain meds. Pain meds are going to potentiate that constipation, so that becomes a little bit of a balancing, juggling act. If you have a pleural effusion, or if you have to go through diaphragm just to get that needle in the right place, we have to do it because we're trying to kill tumor. But that means that we have to look out for pleural effusions as well. And when we are putting so many needles, obviously, even in the best of people, we can have some hematomas happen, and that is cost of doing business, so to speak. I don't mean to sound callous, but there's one line that always comes back to me when I see some small minor problem happen when I'm doing something, is no pain, no gain. Okay? Okay. And then we come to the point where we can't make up our mind. We don't want to burn you, but we want to freeze you. Okay? So we're going to put in probes. These probes are a little bigger, thicker than the IRE or the ablation probes. We put them in the same fashion. The workup is the same. We usually don't do much of cryoablation for liver tumors or for neuroendocrine mets, because IREs and ablations work better for them. But just to give you an idea, if that's what is told to you or offered to you, what we are going to do is, using that needle, instead of heating it up, we're going to the other end of the spectrum, and using those argon and helium gases, create an ice ball. And the ice ball, the temperature that we want to look for is minus 40 degrees Celsius. Okay? That's where nothing is going to survive for that area that has minus 40. Some people do go to minus 20 and call it good. Yes, they have a 95% response at minus 20, but at minus 40 you have a 99% response. So yes, we are going to go to minus 40, which means it's going to be a bigger ice ball. Okay? It disrupts cellular mechanism. It just freezes those membrane channels. This is what the biochemist told me. Freezes the membrane channels. Membrane channels become leaky, so the cell desiccates. Good. It dies. Yes. Good. I'm good. So that's how it looks like. These are the needles, and that dark space there, that's the ice ball. This is the ice ball with the needles removed, and that's what it'll look like. Okay. You can treat larger tumors. You can treat tumors more precisely because the ice ball is very visible on CT. So we can always do this with CT and see how far we are getting the freeze or kill zone. The ablations and the IREs become a little more challenging because when they work, they start producing gas bubbles, which becomes very difficult to track, and gas bubbles can move around in the tissue itself. So you don't really know exactly the precise margins, which is why we always burn a little more than the size of the lesion. The downside of cryoablation is, remember Eric talked about hemostasis to try and stop the bleeding. He uses fancy gels and creams. What we have to do for ablations is we do something called stract ablation or a cautery. Everybody's heard about cauteries, right? So you essentially burn off the sort of raw surface so that it doesn't bleed. With cryoablation, you really can't do that. Until now, they weren't able to get the probes to do both the freezing and the burning, which is why bleeding used to be an issue with cryoablation. You have to have large helium and argon tanks, pressurized gas, so you need different safety precautions for that. So it is done in very certain specific settings, but not very often. It's done more for renal tumors, but that's not what we're talking about. And then just because we want to have something more, there's microwave ablation, which is actually now getting more and more popular, and it's sort of slowly phasing out the ablations for standard tumors or straightforward tumors. It's a single needle which you can use to burn up to 3 centimeters of a tumor. It's much faster. Placing the needle is the same as placing an ablation needle. The patient perception of pain and soreness for some reason is less than the ablation. I'm not exactly sure why. They say that it's because it spares nerve endings, but that's histologically been shown to be untrue. So I'm not sure why the pain reaction is less, but it is. However, microwave can quickly get out of hand. I mean, you can read these slides. I'm telling you stuff which may not be on the slides as well. Microwave can sometimes get out of hand quite fast and cause much larger burns than what you anticipated or what you wanted. So you have to be very careful. Remember, for the ablations, the size of burn depends on the probe. So each probe is rated to a particular size, not so with microwave. So if you burn for 6 minutes instead of 4 minutes, then instead of a 3 centimeter burn, you're getting a 5 centimeter burn. If there's nothing around it, then no harm, no foul. But if there's something close by, then that can be a problem. So you have to be careful about that. Number two, in the initial stages with the initial experience, there were issues about 1 to 4% of the time of blood vessels developing bland thrombus. So not tumor thrombus, but just bland thrombus with this. That has largely been overcome by more refinement and more careful attention to detail. Okay? So then, having said that, we're not going to stick you or poke you or burn you anymore. Now we're going to try and put catheters into you. Okay? So we're going to put a catheter into the artery and try and treat it from the endovascular approach. The one that I'm going to talk about, like I said, because that's the most prevalent, is Y90 radioembolization. We're essentially going to drop the equivalent of a nuclear bomb in your liver and kill the tumor. If the bomb kills everything, nothing survives, tumor doesn't survive. So it's a pure beta emitter. And for you ladies out there, it decays to zirconium. Does anybody know what zirconium is? So, yeah, diamonds are forever, right? Exactly. So, with not real diamond though, sorry. So what it does, it emits betas, and these penetrate for about 2 to 2.5 millimeters in tissue, and they cause cell death. The liver has an amazing tolerance for this, so that is why we can do this. And we have developed, at our institution, we do it in a very specific manner where we don't treat the entire liver or half a liver unless we need to, because there are multiple tumors. What we've started doing is going more and more and more and more focused, to the point where we are doing some things like segmentectomy endovascularly, which will make Eric's blood boil. Because now we are essentially doing segmentectomies endovascularly, which he used to do. This is done in a couple of steps. One is a mapping angiogram, where we are going to lay the foundation to where we're going to see. It's going to give us a GPS roadmap of what the blood vessels are feeding it, what we need to do, where we need to treat. Okay, and then the next time around is going to be the therapy. Two different product types. Now, one thing I will tell you, that none of these product types by Medicare standards are approved for neuroendocrine meds. One product type is approved by Medicare for colorectal meds, and the other is approved for primary liver tumor only, which is hepatocellular carcinoma and cholangiocarcinoma. Having said that, when we use this, we use it with the idea of killing it completely, getting a wedge of dead liver tissue with the tumor in it. It works for everything, because like I said, you drop a nuclear bomb in there, everything's going to die. But the challenges we will face, and your physician will face if they are offering this to you, is whether insurance puts up a roadblock. So when we have to do this for neuroendocrine meds or any other tumor other than colorectal meds and primary liver tumor, expect that the turnaround time to getting onto the table for the first step is going to be at least a few weeks, because what's going to happen, we're going to submit it, then we're going to get a denial letter, and you're going to get a copy of it, and you're going to panic, and we're going to write an appeal letter. That appeal letter is going to get denied again, and then we're going to do a peer-to-peer review. And that peer-to-peer review, depending on what the insurance is, can go through multiple levels. So it is a lot of this paperwork that also has to be done. Not my favorite, because I want to get stuff done, but sadly we have to do it. So the TheraSpheres, these are the ones where the radioactive element is loaded onto glass spheres. They're going to stay there in the liver forever. This is the one that is approved for primary liver tumor. And not only that, it is still approved as a humanitarian device exemption investigation. For what reason, I don't know. According to the FDA, the experimental use has been going on ever since we've started using it, which means it's now a 10-year experiment? I don't think so. And then the SIR-spheres, which are same, Y90 on resin microspheres. These resin microspheres are also going to stay there always. But this is the one that is approved for colorectal meds. Again, they say this one is fully approved. It's not exemption, investigational, at least by FDA standards. So small mercies, right? The optimal size of these is very tiny. Think of 20 to 70 microns, so smaller than grains of sand. The idea is to get these things to the tumor and around the periphery of the tumor, and maybe a little bit into the tumor as well. If all into the tumor, great, but they should not be small enough that they escape through the tumor, through the capillaries, back out into the circulation. What you want is it to get trapped into and around the tumor so that the radiation can be effective. So when you do a cross-sectional pathology of this, when we've treated something, what you see is most of the microspheres which have this, they're either in the tumor or around the tumor, with necrosis within the tumor, and not too much in the liver parenchyma. Why? Because the effect does not go more than about 2.5 millimeters. And the tumors, being vascular, suck this up. And that's what we are using to help us treat these. So we're using their own innate characteristic against them. So that's the tumor. You see all these dots, the black dots, they are the particles. You can see them in the blood vessels stuck in there, and that's the tumor. Okay. So essentially, again, not everybody is somebody that we would do this to. We would do this if we have multiple tumors. We have tumors that we can't do any of the other modalities for. Again, multidisciplinary approach discussed in case conference. When ablation is not feasible, Eric is on vacation. And of course, you want to do this on somebody where life expectancy for whatever reason is more than a few months, because if you realize the process itself is going to take 2 months, and if you are somebody who does not have more than a month, There's no point doing this. So the workup is going to be with good imaging. This is where again I need those people in the reading room to do a good job for me, because everybody has to play their part for a good outcome. You have to look at it, look for any abnormal curveballs out of left field. You want to get blood work done. You will get blood work done multiple times just to make sure liver functions are stable and that it's not worsening with each treatment. So, here's a tumor right there. You have blood vessels going to it. You see what we're going to look for is it what kind of blood vessel is supplying it. You see some blood artery. Oh, sorry, arteries right there. The smaller one, the larger one is the vein going towards the tumor. And we know that there's nothing major going on in terms of abnormal vessels or abnormal anatomy or something like that. Okay. So now what we're going to do is the mapping of the first stage. We're not going to treat you at this point. We're going to get information. I'm probably running over time, aren't I? Okay, so what would you like me to do, Bob? Okay, so now we hit the fast forward button. Pre-treatment mapping. Okay, I got pulled into the principal's office for talking too fast, so you'll have to bear with me. So what we do with the mapping is, we do the angiogram, we try to identify which are the blood vessels that are going to the tumor and which ones are ones we should avoid or are going outside the liver. So for example, this angiogram, you see this is going to the stomach, this is also going to the stomach, the rest of it is going to the liver. So we don't want particles to escape over there. So what we would have to do is block those off so that the particles are not escaping out there. Now for example, now when we know this is the tumor, you see this blush, this is some normal tumor vessels. But you also see the small vessel that is going to the belly along your umbilicus. So we need to block that so that the radiation particles don't go there and give you radiation ulcers on your belly. And then what we do is we inject MAA, which gives us a surrogate as to where this actual treatment particles are going to end up. Because after all of this, we still want to know what is going to land in the tumor, how much is where we are going to inject it from good enough, and in everybody, even in normal people, some of it is going to escape to the lungs. We need to see how much, because accordingly we have to titrate the dose. So once we do all of that, they give us the lung function. We find out whether we missed anything, because then the surrogate particles might end up somewhere else, and then we have to scratch our heads. What did we miss? Okay, and this is what an MAA scan shows. Shows that it's more in this one, tumor localization, mostly in the liver, nothing going outside the liver, so that's good. We have to be careful when we modulate the lung dose or the tumor dose, because we don't want radiation to be too high for the lungs, because regardless of what happens, there is going to be some amount of escape to the lungs. Lungs are much more sensitive. When we do the angiogram and the MAA scan, there might be some things that prevent us from doing the actual treatment. One is if too much goes to the lungs. That means a lot of the doses will end up in the lung, not much in the tumor, because the tumor has big vessels instead of capillaries in their big shunts, intratumoral shunts. Or if the liver function is so bad that when we do this, we'll put you in liver failure. And again, for metastatic disease, that's usually not a concern. And of course, if you have bad lungs to begin with, because if you have bad lungs, your ability for the lungs to tolerate this goes way down. Okay. Then once all this is done, we order the doses. They are customized for each patient, for each tumor, and that's why they have to be done on a particular date and a time. And that's where we find a lot of the confusion happening, because once it's done, our schedulers will call them, hey, you have to be here on Thursday at 12 because the dose is for this Thursday between 12 and 4. I've got tickets to Bumbershoot. Can we do it on Wednesday, please? Or maybe Thursday in the morning? No, sorry, no can do. Okay. Usually tolerated very well. Most common side effect is a lot of fatigue, even more so than the feverish feeling. That's what patients tell us the most. And what we do is once we treat the patient, we do the dose, we send them to the nuclear medicines scanner, we do the SPECT CT, that monitor them for a few hours, and then you go home. We do follow-up imaging in about 2 months. And this is what the PET CT, this is an older slide, so it's not as good, but essentially it shows us the localization of the dose in the tumors itself. We will talk to you, or our nurse practitioners follow up with you once you've been treated in about a week or so, make sure things are going okay. We'll obviously get more labs. Just a few examples. This is two big tumors in the right lobe of the liver before. And then after, what is it? You see the whole thing is shrinking down. Left lobe, left half of your liver is increasing because the right half of the liver is shrinking down. And this went on. The true effects of radiation embolization can be seen almost 6 to 9 months down. So don't be worried if at 2 months you don't see complete response. It takes a while sometimes. So for like I said, these are mainly approved for something else than neuroendocrine tumors, but we've had very good results. Okay. The advantage of this is that Y90 currently can be done only for liver, and most of the neuroendocrine meds are to the liver. Yes, they do go outside. Once in a while they go to muscle, iliacus muscle, etc. For those we can do the ablations. Stick a needle and burn you, or freeze you, or electrocute you. They are highly vascular, so they're going to suck up anything that you inject into the artery. Little do they know when what they're sucking up is going to kill them. Okay. Having said that, when they die, they will release all sorts of bad humors. So we need to make sure that we control you well. Okay, otherwise it's going to be, what the hell did that guy do to me? I feel worse. 2 weeks later you'll feel better and your tumor's gone, but for that 1 week you'll be cursing me. Okay? Just an example. One tumor, you see this hypervascularity, that's the mapping angiogram. It tells me that I don't have any abnormal vessels or vessels I need to be worried about. I can treat from right here because that's going to get the entire tumor. That's what it looks like after 2 months of being treated, a big black hole compared to what it was. Yes, there is some innocent bystander damage, but that's like taking a wedge of liver out, and that's, no pain, no gain. Another patient, single lesion. This is how the scan is in nuclear medicine immediately after delivery of the treatment. Look at how much it's sucking up. It's kind of on a suicide mission there. A little bit goes to the surrounding liver, but it's all concentrated in the tumor. And that's how the tumor would die. Thank you.